Janina.
Thank you so much.
All right, moving on to our next speaker. Let me pull up PowerPoint here. It is my honor to introduce an international speaker. This is Dr. Jeroen Bogaerts, coming to us and signing in from Radboud University in the Netherlands. He's professor of open and endovascular neurosurgery. He got his MD in Utrecht, and he's also master's in clinical epidemiology and neurovascular diseases, and then a PhD in quality of care, specifically around aneurysms. And I saw his talk last year on this topic, and it was really exceptional. He's also chairman of the Foundation for the Promotion of Quality in Neurosurgery. And today he's going to be speaking to us from the Netherlands about some work he's been doing on quality of care surrounding dural arteriovenous fistula management. So thank you very much, Dr. Boogaerts, for signing in and speaking with us. Really looking forward to your talk.
Hello, good morning, and thank you very much for the invitation. I'll start up my presentation. Can you see my presentation?
Yeah,
Yes.
looks good.
Okay. Minimize you. So thank you once more for letting me join you in this excellent meeting. No relevant disclosures for this presentation. So I'm from the Netherlands, and the Netherlands, of course, you know, all from Amsterdam and the tubes and the windmills. But I'm from the eastern part of the Netherlands. It's in Nijmegen, actually. We recently had a new building, the hospital, and for the fistulous lesions in the AVM, we have quite large referral area. Actually, it's large east part of the Netherlands. Those patients with fistulous lesions come to Nijmegen for treatment. So the outline of my presentation is on the cranial fistulous lesions, and in particular mainly on the dural arterial venous fistulas, but also took the opportunity to tell you something about cortical cavernous fistulas and some case illustrations for relevant considerations. So my take-home message. So what's important in fistulous lesions? Well, that's quite obvious, actually. There's one thing, that's everything. Everything is important in fistulous lesions. And there are so many aspects that are important, and I would like to go over some aspects and would love to treat it, discuss it on a systematic way. And to discuss this on a systematic way for the treatment of fistulous lesion, the first question is always, do I need to treat this? And you can ask this question for yourself from a clinical perspective or from a pure imaging perspective. Secondly, you have to ask, what are the options to treat? And you have to, of course, balance your treatment results versus the complications, so your success versus your complications. And those determine finally your treatment. So this blueprint is used for all the fistulous lesions. So what are the general aspects from a clinical perspective, from an epidemiological point of view, like the dural venous fistulas are 10 to 15% of the intracranial vascular malformations, and they are overrepresented in the posterior fossa, up to 35%. Typically middle age, the mean onset in the 6th decade, and there's a female preponderance. However, men are more likely to present with hemorrhage. So the pathophysiology of those fistulas, it's not known actually. They're associated to dural sinus or venous thrombosis, but also with hypercoagulable states. There are many And also thrombosis might be also the consequence of a dural atrial venous fistula. So it's really not well known. And it's also known that sometimes it might be the result of trauma or infection. So from clinical perspective, how do those patients present? Typically, they are asymptomatic, can have pulsatile tinnitus, or have non-hemorrhagic neurological deficit, which is like epilepsy, recurrent thrombosis, or mass effect of a draining vein. And the most feared complication, of course, is the intracranial hemorrhage, intraparenchymal, subarachnoid, or subdural hemorrhage. And from an imaging perspective, we all know the Borden classification with what type 1, 2, and 3. Let me briefly summarize those. So in type 1 fistula, there's an antegrowth flow into the sinus without any corticovenous reflux. In a type 2, there is the corticovenous reflux, which makes it very different from the type 1. And the type 3, which is more rare, is a purely flow with on the not within the sinus, but exclusive on the corticovenous reflux. But also Cognard, he described also in the same year his classification, which is a little bit more elaborate, but I think it's a little bit more useful. So this type 1, which is the dural, the drainage into the dural sinus with antegrowth flow. The type 2 with a retrogrowth flow, however, without any corticovenous reflux. And the type 2B is the antegrowth and flow in the sinus, but with corticovenous reflux. And type 2A and B is combined, so then you have both retrograde flow and flow in the corticovenous reflux. So type 3 is a drainage directly into the subarachnoid veins, so only the corticovenous reflux. And the type 4 is the drainage directly into subarachnoid veins without venous ecstasy, with venous ecstasy, sorry. And the type 4 is a little bit distant type of fistula, which is the drainage into the spinal perimedullary veins. So is there a need to treat? What do we know from the natural course? If we see the patients who present to the departments, typically most of the patients, they present with hemorrhage. And we know also that those patients who present with hemorrhage have a higher Borden classification. And that's what we see clearly here in this case series of all. So are they dynamic lesions? Yes, and actually no. So they could be dynamic, but the real risk of aggressive transformation, so from a low Borden grade 1 to a higher grade, it's actually very rare, 1 to 2%. And it could be due to venous stenosis, thrombosis, or increased arterial supply, or there could be some change in symptomatology. Spontaneous occlusion can also occur, but it's also very rare. So if we look more in detail to the natural course, we know that the risk of hemorrhage, especially in those patients with corticovenous reflux, is high. So there's a high risk of hemorrhage on the annual based rates, but also on the long-term 4-year rates. And also mortality is high. So it's a dangerous constellation if there is a corticovenous reflux. So what are the options for treatment in general? Of course, conservative management, embolization, transarterial. So the success presentations of large series meta-analysis are relatively high for embolization, about 80 to 100%. Transvenous is a little bit less effective, but still very effective. So open surgery is the skeletalization of the dural sinus. It's generally very effective. And stereotactic radiosurgery, which is less effective, about 60 to 70% in general. So these are the options. So let's go over some case examples. This patient, male, 62 years old, with acute numbness in the right side, a slight motor deficit on the right side, a slight dysarthria. That is hyperdensity on the CT, but no signs of bleeding. And that is on the angiography, this extensive fistula on the apex of the petrosum, with filling from the internal carotid artery, but also from the external carotid artery, with a large vein. So this is clinical presentation. He had some neurological deficit. He has also maybe some hemorrhage, but there was not very clear. And the imaging, so it was a Borden 3. I'll go back for the image. You can see the direct to this cortical vein. It's not directly into the sinus, and it's a Cognard type 4. So there's also an indication for treatment. So what are the options? Embolization, definitely an option. Open surgery, option, and stereotactic radiosurgery, not an option because it's not effective and it takes time before it has its results. So my considerations for this was because of the difficulty fine network of the arterial supply, it was not possible for transarterial approach for embolization. And I was not secure about the transvenous approach, quite extended, quite long route through this venous network. So I decided to operate, and here you see the left lateral suboccipital trepanation axis. You see the Dandy's vein, you see the tentorium on the right upper corner, and you see in the central the extended vein. It was easy to clip off this, and you see also the slide network more on the dura, on the petrosum, which could be coagulated. I did not only do a infratentorial, but also supratentorial, so I would subtemporal and also coagulate the dura and the fine network and have this postoperative result. So another case with 66-year-old woman with pulsatile tinnitus since 1 year. You see again this fistula with this feeding from the probably Bernasconi Cassignari branch, and also from the external, from the middle meningeal artery, which was a posterior branch, which was very hypertrophic. So do we need to treat? Yeah, pulsatile tinnitus can be very invalidating. So yes, but there is an indication to treat. And based on the imaging presentation, should we? We could. It's Borden 1, Cognard 2A, so we could. It's not necessarily. So what are the options? You could embolize, do open surgery, or stereotactic radiosurgery. Again, stereotactic radiosurgery could be, but it's not that effective. So generally, we don't choose for that. Only if other options are not possible. So what are the technical considerations for embolization? So should we go through the artery, through the vein? If we go to the artery, which branch we should need, and which material, and which catheters? So for this case, we took a triaxial arterial approach through the middle meningeal artery. And typically, our strategy is to take the smallest branch, because if you take the smallest branch, you have this wedged position. The wedged position means that you have your closed, there's no space left between the vessel wall and the catheter, which means that it is easy to make a plug, and the glue or the onyx, whatever you use, will go forward. You see on the right side the selective injection through the microcatheter in the smallest feeding branch. And from this one branch, you can accomplish total occlusion of such a fistula, which is, generally speaking, highly successful. And so here you see again once more the branch, and also you can have with one injection only to the MMA, you can have a nice occlusion of the fistula, also from the part filling from the internal carotid artery. So there's some technical nuances. Sometimes you can decide to close off the sinus instead of to go through the artery. And for that, you can use balloons. There's the Copernic balloon, which is a relatively large balloon, and you can embolize around the balloon, or you can also use coils, and there's several techniques to really close off the sinus. Normally, our strategy is to preserve the sinus, because if you don't see it in the initial images, it doesn't mean it's not there, because it's sometimes due to the flow, you cannot see it. So here's another case, male 63 years old, with a known vascular malformation. It was not known what this actually was. It was from another hospital, but he refused further treatment, and then he presented with a bleeding. With the diagnostic angiography, we see this extensive ectatic veins, cerebellar, with feeding from dural branches from the vertebral artery, especially from the right side, but also from the left side. So again, is there a need to treat? Yes, because there's a hemorrhagic presentation. So what's it from an imaging perspective? It's a Borden 3, so that's direct on the cortical veins. It's a Cognard 4. So what are the options? Again, stereotactic radial surgery is not an option. Embolization, open surgery, both could be an option. I try to access this through the small branches from the dural branches from the vertebral artery, but unfortunately I was not able to do so. Therefore, I shifted to surgery, and here you see the opening and the skeletonization and the coagulation of the dural branches, which is sometimes a little bit bloody, but it's highly effective. And this is the post-op images from this case. So surgery is sometimes a very valid option. So here, another case, male patient, 57 years old, with gait disturbances, with bladder incontinence and bowel dysfunction. And you see the lower mesocephalic hyper intensity and congestion. And doing the angiography showed that the branch from the occipital artery was fistuling, and it gave congestion. You see the perimedullary veins, they are congested, and the cause of the symptoms. So this was quite a straightforward case. The only thing was the support we needed for this case, because it's quite a long way, quite tortuous. And therefore, you need this triaxial support to have sufficient pushability of your microcatheter. So triaxial support in such a case is very important. And this is the control angiography from 6 months with resolution of the symptoms, and also the perimedullary veins resolutions. So also not only the dural fistulas, but also would like to tell something about the corticocavernous fistulas, the CCFs. For this, we have the Barrow classification. And let me go briefly over it. The type A, which is the direct connection between the internal carotid artery and the cavernous sinus, most often also in case of trauma. You have the indirect case, the indirect type B, which is the connection between the dural branches of the internal carotid artery and the cavernous sinus. And a type C, which is the dural branches of the external carotid artery and the cavernous sinus. And type D, actually a combination of type B and C. So this is a typical case, 52-year-old male with proptosis and intermittent visual deficit on the right eye and chemosis. And here you see the slight filling of the cavernous sinus. You see it maybe more clearly on the lateral image on the right side. And I have here more detailed image. You see the venous filling in the early phase, the too early phase of the cavernous sinus. also extending to the contralateral side. And this was a fine network from the internal carotid artery only. There was no filling from the external carotid artery. So this was a barrow B. So this gives directly some difficulties, because if you have only this tiny network, you have difficulties in transarterial access. Actually, it's hardly possible. So for this, the transvenous access was chosen. Also here, you need triaxial support to enter the cavernous sinus, which might be sometimes a little bit challenging. And here you see the coiling of the cavernous sinus. And the way, the strategy is you start at the most distal part and then work your way backwards to the more proximal part. And you see on the right lower, you see the post-operative, post-coiling images. But sometimes you have difficulties in having the transvenous access on the normal way. And here you see also this patient with indirect filling of the cavernous sinus from the internal carotid artery, but also from the external carotid artery, so it's barrow D. And there was no clear route for normal transvenous access. So in this case, we decided to go to the superior ophthalmic vein, because it was also very extended, and you could already see it from the outside. So it was clearly, you could, like with a fanflon, you could like puncture and through your fanflon, put the microcatheter and just coil off the cavernous sinus. And then here you see the results with no filling anymore of the cavernous, of the fistula. So here, this is a case of a direct carotid cavernous fistula, with female 68-year-old with subacute headache, with ptosis, dipaplia, and a motor deficit on the left hand. And you see this impressive image on the middle, which you see the carotid artery injection, internal carotid artery injection, in which there was hardly any filling of the intracranial vessels. And after 4 days, we planned her for embolization, and you see there's actually no filling anymore of the vessels through the right internal carotid artery. So in this case, we decided to preserve the internal carotid artery, go directly through the opening in the carotid artery in the cavernous sinus, place a stent to secure the internal carotid artery and coil off the sinus. So this is again the pre and post-operative image. So it's important to know first of all your team. It's a teamwork. So for me, it's a little bit different because I do also probably like most of the neurosurgeons in the US. I do the endovascular, but also open surgery. You have to have a good equipped angio suite or OR, and you have to have knowledge of your devices, your catheters, and your embolic agents. Especially helpful are the detachable tip catheters, which are, at least for me, the Apollo and the Sonic, which are very useful catheters. Also, the small balloon catheters nowadays are very useful in treatment of those fistulas. Also, the embolic agents, there are a lot of them. I usually work with onyx and squid, which are most practical for me, but there are many others and many other strategies. So a hybrid OR is especially useful for those cases you treat open, so you can have direct intraoperative control whether the treatment is complete, yes or no. So this is a little bit like the overview on the Fistulous, dural arterial venous fistulas. So depending on the clinical symptomatology, the angioarchitecture should be conservative, embolization, surgical, or stereotactic radiosurgery. So this is kind of our workflow for those cases, but there could be others. In general, we tend to treat the aggressive one, And I must say we shifted the last years mainly through embolization. So nowadays it's rare that we would do open surgery on fistulous lesions. And most of them are treated endovascularly, transarterially, or transvenous. So in conclusion, CCFs direct mostly requires treatment. Indirect, it's very much dependent on the symptomatology or the radiological findings. So what is important? Clinical presentations and the natural course, imaging characteristics. You have to identify the high-risk patients for bleeding, those with corticovenous reflux, and you have to be aware of the therapeutic options and the results and the risk of complications. So thank you very much for your attention.
Jeroen, thank you very much. That was a great talk. For the residents, you know, it might be 2 points I'd like to point out about Jeroen, not specific to the talk, although that was also excellent, but just to the experience. In a lot of ways, Jeroen, feel free to correct me if I'm wrong here, but in a lot of ways, sometimes it feels like in Europe, the growth of neurosurgically driven interventional procedures is that they're about 20 years behind us on a political spectrum. And Jeroen's really a tremendous pioneer in that space, very involved in the ANS, and really the leader of the first generation of true dual trained neurosurgeons there. His mentor, Joost, might be the very first, but he's like a complete iconoclast and stands alone. Jeroen's building a network of really amazing people. I had the good fortune to be out there recently in the Netherlands, and you know, you've got now the last time I was there 8 years ago, there were like less than 5 around Europe, and now there were like 15 from various major cities. And so separate from what that means for the field of neurosurgery, it's good for patients to have a mixed background of people treating diseases and bringing their different perspectives to it. So Jeroen, thank you for all the work you do in that capacity.
Yeah, thank you for the opportunity to present here. And yes, indeed, it was in Europe. We're way behind, and I think, I mean, it's good to work in a team with your neuroradiologist, but it's very politically in Europe that neurosurgeons are kind of blocked from endovascular, and nowadays, as you said, things are changing. There are even now 30 neurosurgeons in Europe who perform both open and endovascular procedures. And the way they could enter the field is that they have their hybrid OR, that they have the possibility, they have their own angio suite at the OR, and that makes it for them possible to enter the field.
Mm-hmm.
Jeroen, I had a question for you about that great talk you gave. So the cases we end up discussing the most are the ones with simple cortical reflux and either no symptoms or tinnitus that doesn't bother them so much. So orthograde flow, non-occlusive, non-occluded sinuses, orthograde flow, cortical reflux, with or without minor symptoms. And in your scheme there, it looked to me like if they had symptoms, you would operate, and if you didn't have symptoms, you wouldn't operate. But sometimes those symptoms are almost like an incidental finding.
So thank you very much. So for the if there is cortical venous reflux, we tend to treat them, even if they don't have any symptoms, because we consider this as high risk for hemorrhage. So we treat even if they don't have symptoms. So that's our strategy in general. Yeah.
Yeah. Okay.
Yeah.
Trevor, do you have a question?
Yeah, go ahead, Chris.
Well, if you want to comment, go ahead. But I was going to call on Trevor.
Have at it, Trevor.
Jay, that's pretty much
Before Trevor.
your.
Yeah, that's what I was just gonna say. That's pretty much our threshold too. If we see cortical venous drainage, our feeling from the scales is the hemorrhage risk is quite high, and that should be the ones that really sometimes confound us when there isn't, but it's symptomatic, and then you're, trying to figure that out.
Yeah, it depends from the symptomatology. If there's no cortical venous reflux, this pulsatile tinnitus, as I said, it can be very, very disturbing for the patients if they cannot sleep or whatever. So then we also we have a quite low threshold to treat them.
Thank you very much for an awesome talk. I just had two quick questions. In some of the first cases you showed for the dural AV fistula, where you had contribution from the external carotid as well as intracranial, do you have a paradigm of where you would like to try to treat the external contribution first versus the intracranial? Or, I mean, obviously it's an individual basis, but was wondering if there was a standard thought process there. And the other was when you mentioned for the direct cavernous fistula, using a stent. I imagine you were talking about putting a stent over the ostium or the opening into the cavernous sinus. Do you prefer to use a stent versus a balloon there and then try to come transvenous once you have that ostium or that opening blocked? Do you have a preference between those two, or do you try to get away with a balloon first and then go to a stent? If you're able to identify that opening, that was just my question there.
Okay, well, thank you very much. Yes, so for the first question, I tend to go external. So that's often the most simple axis and the less risk in general. But of course, it depends very much where your fistula is. But in general, it's the strategy of choice to go to the external, and often you can accomplish also the closure of the internal contributing branches. I showed also this one example. And as for your second question, yes, sometimes this hole is quite big. So then I'm not sure whether if I deflate the balloon, whether it is secured. And it's still, you could do a balloon and then deflate, and if you're not secure, then place the stent through the balloon catheter to your septum. That's also a valid strategy. Yeah, in this case, I just choose to have to secure the internal carotid artery first and jail the microcatheter. So, but I think both are valid options.
Thank you so much.
Yeah, I just.
Aaron, what are you doing for?
Oh, sorry. Go ahead. Z, you had something?
No, that's right. I was going to ask about follow-up, but if you want to go first, go for it.
No, go ahead.
Jeroen, I was going to ask, what do you do for follow-up if you have closure and it looks like it's cured? Do you do a delayed angio? Do you follow up with non-invasive imaging?
Yes, with the default 6 months angiography. Yeah.
That's what I've been doing too.
Yeah, we use the 4D CTA, but for small remnants, it's not that good.
I have a question. First, thank you for a wonderful talk. Part of your strategy in treatment, you described attempts at preservation of the venous sinus, even when on initial evaluation, it appears like the sinus doesn't have physiological drainage, either if it's fully consumed by the fistula or if it's retrograde. Do you find that there is any additional benefit in preserving sinuses in these situations?
I mean, you could sacrifice it, of course. If there's like the contralateral side is open, then it's no problem. But my philosophy, there's no need to sacrifice it. Yeah, of course, if you cannot treat the fistula otherwise, then you should. But normally you can treat the fistula just through the transarterial route, and then there's no need to sacrifice it. So if it can be preserved, I tend to preserve it. That's the philosophy of it.
Got it. Wonderful. My other question is, I think in the overwhelming majority of times when we have patients with hemorrhagic fistulas, we find that they are in the Conyard 2B or above classification usually. Do you think it would be an acceptable strategy in certain situations to treat a fistula to bring it down to a Conyard 1 if a cure is not achievable?
Oh yes, absolutely. Yes. I have such cases, and I think it's a very valuable strategy. I mean, you don't have to go all the way. You have to just protect them from bleeding. And if there's some antegrade flow, it's like a low grade, then there's no risk. And there could be only symptoms, of course, but you should take away the risk, which is the primary thing. I completely agree. That's a very valid strategy in very extensive fistulas. In those cases, you cannot accomplish a complete obliteration. Absolutely.
Thank you very much.
Well, the other thing I wanted to throw out that was a little less clinical, that's why I was going to let everyone else go, was just for the residents, getting to develop friendships with people around the globe is one of the real treats of being in academic medicine. And I'm sure Dr. Betterson can share. I know he has some wonderful relationships, and Dr. Germano and the rest of us on here. Jeroen's been one of those for me, to be able to go to the Netherlands and be part of his career. And I don't have it on my computer, otherwise I'd share it, but I got to dress up in a funny Dutch outfit for his PhD ceremony and stuff, which was pretty awesome and made for great memories. And so I would just sort of highlight the fact that for all of you, it's one of the real great positives and benefits to a career in academic medicine, and I'd encourage you all to embrace that and realize it's a great thing.
Yeah, that's pretty cool that you just signed on from far away and got to share what you're doing. I also think that you have underestimated, Jay, the unique success of your program here in bringing together people from all the different specialties into one cohesive program. We may be a few years ahead in terms of breaking down barriers in our leading edge in this country, but it really is the leading edge that you guys are doing, because you can go across the park, and in many other places, politics just don't allow it. And as Jeroen mentioned, sometimes it's where the machine resides that determines who gets to do what. So some crazy economics beyond politics that allow you guys to succeed so nicely here.
Yeah, isn't it funny? I'm talking to the guys in Europe, and you can share your thoughts, but that becomes a big part of it. Is the angio suite down in radiology? Do they move and work? It's interesting to hear how one strategy many people are using is they're doing the procedures with cardiology, which is what Nick Hopkins had to do in the 80s for him to be able to do neurointervention as a neurosurgeon in the United States, and then otherwise building them in the operating room.
Yeah, that's absolutely true. And also the changing field of stroke, which always puts high demands on the interventional neuroradiologists. So they're not sufficient ones in Europe, and this opens the field for neurosurgeons. So
Right.
it's changing.
It's wonderful. Well, thank you very much, Jeroen. Thank you for taking the time out of your day. It's the middle of your day to come and join us. We really appreciate it.
Thank you.
Bye, Jeroen. Thanks a lot, everybody. Have a great day.
Great grand rounds.
Thanks, everyone.